This is I'm going to present the case. This is a 61 years old woman with history of hypertension, dyslipidemia, and type 2 diabetes. Just the week before an STEMI, we treat the culprit lesion. In this case, was the circumflex, and also she has a proximal LED disease. That is the staged procedure that we're going to do today. And the echo shows preserved ejection fractions and no other significant findings. And I'm going to show you the angio. There's no significant lesion in the coronary artery. So you can see the culprit lesion in the circumflex that was treated, and we're going to treat that lesion in the proximal LAD that I'm going to show you here. And as you can see, we have a severe calcification, and that is we're going to use plaque modification technique. Our society has a position paper regarding the plaque modification technique to treat calcified coronary lesion. That is led by Alfonso Grado. And according to this algorithm, we have to use plaque modification techniques. But which one? In our case, our institution is doing the roller coaster trial. That is a study to decide which technique we're going to use. In this case, our patient was randomized to the lithotripsy treatment. So this is the plan. We're going to use plaque modification techniques. In this case, lithotripsy, and for we're going to do imaging guided PCI.
And as you can see, it's a very big vessel. Probably the reference diameter is 3.9 more or less, the luminal diameter. And this is a calcified, a severely calcified lesion, as Silvio said. So our plan is to prepare the lesion with lithotripsy. We was in the debate before, Santiago and me, if we can go directly with the shockwave balloon or it's better to predilate. A little bit, probably we are going to predilate because I struggle a little bit to cross the wire. So we're going to predilate slightly with a 3.0 balloon. You can see the lesion in the screen. It's a thick lesion, all the circumference, 330 degrees here, probably is the wire, so the whole circumference. And that's all. Let's predilate a little bit. Okay, while we are predilating the lesion, Alicia is preparing the shockwave balloon that, as you know, needs to be prepared perfect without any air inside the balloon, because if there is any air, the sonic waves are not going to do their job. And also, if you have a rupture of the balloon, the complication could be worse. You can see this loop bone effect at 18 atmospheres. Okay,
Doctor?
Yeah. Saroto. Sí. The balloon has been broken. Okay. So they expected. We are not going to inject, just a little bit to control that there is no complication, but the blood pressure is okay. You can see the shock beats there. Okay. Yes. We have to go up to 6 atmospheres and wait to this signal to get down. Okay, I think we have to do another run up to 4. We check the position. Okay, we are there. It's recommended to perform at least 20 pulses in each lesion. I think the expansion of the balloon is quite good. 6. It's another thing different than before. What do you think?
Haría otra.
Vale.
One more.
We are doing one more. Let's give the patient a little bit. Okay. One more. 4. Okay. We're going to check their extra beats. Otro tercio de frente, por favor.
Un
6.
Megatron 420.
420 está ahí abajo, ¿vale?
¿Nos lo echas?
Aguanta un momento. We're going to check in another projection. Okay, go down. Yeah, this this calcification below the balloon, but I think the expansion is quite good. Okay.
Sí.
Sí. So another thing for this patient. Pequeño test, por favor, que no hay nada raro. Okay, the flow is recovered. There's no perforation. So another thing is that the patient is allergic to cobalt. So in the previous procedure, we implanted a Megatron stent, synergy stent, and we are going to do the same because, as you know, the composition of this stent has no cobalt, cobalt, platinum, and the Megatron stent is the evolution of the synergy for big vessels with higher strength, radial strength. And as we are treating a 4 millimeters vessel, we are going to implant this stent. It's a common practice here. This is quite useful, in my opinion, is to do a small injection of contrast before retrieving the balloon, just in case you have a perforation. You have the balloon there to do an inflation and then think. So I think everything is okay. The ECG normal. Let's see the distal part. Obviously, there is a slight under expansion in the proximal mid part of the stent. That is the side of the more calcified plaque. Let's see in the cranial view the distal end of the stent. I think it's nice. So we are going to perform the OCT. In this case, of course, the patient has been included in the roller coaster trial that is randomizing shockwave versus rota versus laser in these calcified lesions.
Sí, lo deja.
But probably one question could be if we have had chosen the same strategy if the patient hasn't been included in the trial. And probably in this case, it is the best option because it's not a critical stenosis, and probably shockwave balloon can cross. In this case, we have predilated a little bit.
Lesion.
Yeah. And it's proximal, it's a big vessel, it's short, so probably it's circumferential. So probably shockwave for this case.
For this case, is the best option.
Is the best option in our opinion. So we are ready to
continuar. 54.
Sí, la corta, ¿no? Píllame aquí, por favor, la guía, Santi. Sí, espera, tengo que subirla.
Pone 16.4.
And also, regarding the calcification, you have seen the circumferential calcification, but also this a thick plaque, and probably, be careful with the wire, probably, la tengo ahora ya. Rota is not going to do anything in this deep calcium. And laser could work there, but this is a controversial point. As you know, that classically laser has been said to do nothing to modify calcium. It is true, but only in pure calcium. But as you know, in the coronary arteries, there is no pure calcium. It's always mixed with fibrous tissue and all the...
Purgamos.
Yeah. So we are ready for do the OCT pullback. I'm going to retrieve the OCT catheter and then we can analyze it. Si nos dais el joystick, bueno, no tenemos joystick aquí. Ayúdame aquí, por favor. A quitar esto. Ya de la... Y esto. So Santiago Jiménez Valero is analyzing the OCT. He's our expert in coronary imaging. And we'll see. In the rapid pullback, probably there's some malposition at some point, but the areas are quite good.
So we can hear.
This is the Ultron software.
The distal border is good. There's no dissection with expansion at this point.
A little bit malapose there, but
this is small, only two
yeah,
struts and
it's a small malposition there.
Little length. There is some asymmetrical expansion due to calcium in the.
I don't know if you are
this
hearing Dr. Esquivel Valero, so I am going to repeat the things he's saying. You can see here the software. And doing the measurements, probably in this mid-proximal part of the stent is the minimal stent area.
O sea que el área mínima del stent es aquí.
It's near 7.5, the MSA. Okay. Let's check again everything.
There is some slight under expansion with very near struts, but the minimal luminaria is good. The software indicates a 74% expansion. That is quite near 80%. We can use
again, Santi, que no sé si te oyen. ¿Oís a Santi? Okay, continue.
One option could be use again the lithotripsy, but we have some doubts about the effect on the polymer, etc. And the result is that with some slight mild under expansion,
yeah.
in the midpoint of the stent, but the minimal luminaria is quite good.
Yeah, the thing is that what is the perfect or the optimal expansion percentage of expansion? That is the primary objective for the study. In the studies, we are dividing always this thing, 80, 90%, but in the studies, in the Illumination trial, the majority of patients have memorized this 80%. So the area is quite good, it's 7.5. I don't know, to be honest, if we can improve it with more, not now, but also at the beginning with more shockwave pulses. So probably this is the best option. The other option is to, as Santiago said, to perform again more pulses inside the acutely implanted stent. We know that there is a controversial point about this for damaging regarding damaging the polymer, but we have data of the group of my friend José Manuel Montero that after 2 years of follow-up, this acutely IVL in acute implanted stent has no adverse clinical events. So we should decide with this area. Probably, I think it's enough.
It's enough. The other option is to post-dilate with a
4.0
or 4.
We can post-dilate, yeah. We are going to post-dilate with 4.0.
OCT if it is reasonable result.
Ok, nos dais un 4.0 de NC, 12 o así. So we are going to post-dilate. As you know, in the disrupt trials, the percentage of pre and post-dilatation is quite high. And we can post-dilate with a 4.0 balloon.
We should not be aggressive with post-dilatation because of the dissection and the rupture of the balloon. There is some damage in the vessel wall.
The common sentence, no? The best is the enemy of the good, and the area now is over the thresholds of optimal implantation. But it's true that this part is a little bit under-expanded, so we are going to post-dilate at nominal pressures with a 4.0 balloon. And we can repeat the OCT and this side. Our setup that we didn't explain before, because we have just started before the connection, is a radial 6 French approach. As you know, you can do lithotripsy through a 6 French guiding catheter, and it's quite easy. The technique is quite easy. That is their main advantage against the other plaque modification techniques, that the learning curve is. So as you know, in these calcified lesions, it's difficult to have answers to which is the best option. In every meeting we have, the common sentence is we don't have randomized data, and we are having those data after this trial, the roller coaster trial. But probably the best option is always to select the strategy looking the lesion, the patient, the time of the day is not the same to treat this lesion now than doing in a STEMI at 3 a.m. Of course, it's more important the expertise of the team, the devices you have.
Arriba a la derecha. No. Arriba ahí a la derecha. Iniciar retirada nueva. Ponle si quieres post. ¿No? Vale, dale a continuar.
Es igual, continuar. Comenzar.
Un segundo que estoy purgando. Vale, cuando queráis, comenzar. ¿Tiene? I think it's better.
Let's check it, but our initial impression is that it is better. You can see in the angio, these two small protrusions, probably is there.
¿Quieres salir, Sofía?
Calcified nodules.
Te dejo ahí encerrada.
The beginning of calcified nodules there. But the result is quite good. We also strongly believe in the combination of plaque modification techniques. In this case, we suspected that we were going to be able to cross with a shock wave, with a slight dilatation.
The small luminal area have improved, and you can see here the dissection that is sealed by the stent. And in the proximal ostium, there is no residual dissection in the proximal border. And
it's more difficult to measure areas with this new software, but they're improving
now
it.
The machine say that the minimal luminal area is 8.
We have improved it a little bit, no? 0.6, 0.7. So I was saying that we suspected a shockwave was going to cross, but we strongly believe in the combination of techniques. And if we have a struggle to cross with balloons, probably it's quite useful to use rota, laser, or whatever to make the channel, and then finish with the shockwave. Fine, ¿vale? ¿Vale? Fine. I think it's perfect. What do you think, Santi?
It's very good. The minimal lumen is 8 millimeters square, and the minimal expansion is 76, I think. This is the critical.
Near 80%.
Near
80%.
I think it's quite enough.
Okay, just to recap before leaving you, it is not a very complex case, to be honest, but it was interesting to show the treatment of a severely calcified lesion and a proximal LAD. It's important that this technique with IVL is quite easy, is safe. You can do it by through a 6 French guiding catheter, always imaging guided, in this case with OCT. The patient has cobalt allergy, so we use a Megatron stent that also gives us this increased radial strength, visibility, and this is especially designed for these proximal big vessels. So I think we are done. So thanks to Alicia, Santi, and all the team.